Hello, everyone. Good evening. I just wanted to check. Can you hear me okay? Hello. I just wanted to check the sound, if everything is being heard okay before I start. So if anyone is there, can you just let me know through the chat whether you can hear me just okay? Great. Thank you so much for the confirmation. So we're gonna start now. Um, My name is Lin Tuleimat, and I'm one of the upcoming neurology registrars and an academic clinical fellow in neurology at Sheffield Teaching Hospitals. And today we're going to be discussing the management of stroke, and we're going to go through the evidence-based approach to stroke patients. So we're going to start off with what is stroke essentially. It is a clinical syndrome which consists of a rapidly developing clinical signs, either focal or global, if the patients present with a comatose state, and that causes a disturbance of cerebral function, but it is known to last more than 24 hours, and in some cases can lead to death with no apparent cause that we can identify other than a vascular origin. And there are two main types of stroke classification. It's either ischemic, which is 87% of all the stroke cases that we see, versus hemorrhagic, which is about 13% of all the cases that we see. And it's important for you to know the details about stroke workup and the pathophysiology and how to approach it because it is critical for reducing the morbidity and mortality of patients. Now, from an epidemiological perspective, around 1,500 people have a stroke in the UK each year, and about 50,000 of these die every year. And currently, about 20% of all acute hospital beds are being occupied by stroke patients, and all the long-term beds, about 25% of them are stroke patients. So there is a burden on the patient's health. There is a burden on the healthcare because of stroke and its implications, short term and long term. And that's why it's important for you to understand that time is brain. And each minute which stroke is untreated, that basically equals 1.9 million neurons dying. So we usually are very efficient in assessing the patients and then assessing whether they would be suitable for management, that being thrombolysis or thrombectomy, which we will discuss a bit later today. But it's important to make decisions as quick as we possibly can, rule out all the contraindications and move forward because we're saving more tissue as we go when we do make these decisions precisely, but with less time spent on them. And it's estimated that the cost of stroke in England is around 8 billion per year. So you can see all the implications of stroke as a disease on the patient, on the healthcare system, and financially, and on the patient's long term. So it's very important to know and to follow up with the evidence-based management for stroke. Now, there are modifiable and non-modifiable risk factors that we can work with. And modifiable risk factors are things like hypertension, diabetes, smoking, which are very well known to be associated with increased risk of diabetes. And then there are non-modifiable risk factors such as age, gender, or family history of previous strokes. Now, we identified or categorized the stroke as either ischemic or hemorrhagic. Now, for each of those, there are different ways that they can present or different pathophysiology. So, for example, the ischemic stroke can either be thrombotic in nature or embolic in nature, and we're going to discuss that now in the next slide. However, the hemorrhagic stroke, you'll find that it's either presenting as an intracerebral or tissue hemorrhage or subarachnoid hemorrhage. And obviously, depending on which brain region are affected by either an ischemic stroke or hemorrhagic stroke, you'll see different impact on different functions and the functional outcome of patients accordingly. So essentially, this just summarizes the characteristics of these different stroke subtypes. So, for example, the intracerebral hemorrhage, we'll notice that it's more gradual progression from minutes to hours in patients, while subarachnoid hemorrhage, it's usually abrupt onset, sudden, severe headache, and it can cause focal brain dysfunction, and it's less common than with other types. And the risk factors for bleeding generally include hypertension, which is a very well-known and associated risk factor with intracerebral and subarachnoid hemorrhage, trauma, illicit drug use like amphetamines and cocaine, and vascular malformations that previously maybe were not known as they did not present. And we'll find that there is more likelihood in certain ethnicities, just such as Africans or Asians, than in whites to have intracerebral hemorrhages. In subarachnoid hemorrhage, you'll find that risk factors are mainly related to amphetamine and cocaine use and bleeding diatheses. Now, for the ischemic stroke subtypes, in the thrombotic subtype, you have a stuttering progression. There are periods of improvement in between, and the lacunes, they develop over hours or at most over days, and the large artery ischemia may evolve over longer periods. And the risk factors are the vascular risk factors, so smoking, diabetes, and usually men are more affected than women with thrombotic strokes, and they may have a history of previous TIAs that led to the development of thrombotic stroke. Now, the embolic stroke, it presents as a sudden onset, and there is a deficit maximal at the time of onset. And you can find that sometimes the symptoms that they present with may improve quickly. They have the same risk factors, but as you know, emboli are more likely to develop when patients have heart disease, like valvular heart disease, atrial fibrillation, endocarditis, that puts them at a higher risk of forming emboli and then throwing emboli into the brain. And this is just to show you the differences between all these different subtypes of stroke. So we can see on the left-hand side with the ischemic stroke, we have the thrombotic type. It's a blood clot forming locally in the brain, and consequently, it blocks the blood flow. Embolic is a blood clot that forms in the body and then travels through the bloodstream until it reaches the brain, where it blocks the artery. In the hemorrhagic on the right side, you can see that the intracerebral hemorrhage, it's a bleeding that occurs within the brain tissue. However, the subarachnoid is the one that occurs in the subarachnoid space. And this summarizes to you the different vascular territories for the cerebral circulation. So the most important ones to know are the anterior cerebral artery, which you can see it's basically covering the frontal medial part of the frontal lobes. And then you have the middle cerebral artery, which encompasses a large area from the frontal, parietal, and temporal lobes. And then we have the posterior cerebral artery in blue, which covers the occipital and the parietal lobe, and then goes on to cover the brainstem. And then we have smaller arteries like medial lenticular striae artery, which you see here. The basal ganglia is covered by the medial lenticular striae, as well as the lateral lenticular striae arteries. And these are very sensitive to high blood pressure as well. And with high blood pressure, there is higher risk of strokes in these areas. And these are very important for localization purposes, which we're going to discuss now, to know what does each of these areas present in terms of function, so you know by examination which area is affected. So we have the Oxfordshire classification or Bamford classification for strokes, which divides them into total anterior circulation stroke, partial anterior circulation stroke, and posterior circulation stroke, and lacunar syndrome. And we're going to now go through how each one presents and how to differentiate between them. So for the total anterior circulation stroke, you have these clinical features, which include hemiparesis plus higher cortical dysfunction, which usually means dysphasia or visualospatial neglect, and homonymous hemianopia. So all these three need to be present for us to be able to say this is a total anterior circulation stroke. And usually on a vascular basis, you'll see that the proximal middle cerebral artery is occluded, or the internal carotid artery is completely occluded, and that's why it's presenting or causing a total anterior circulation stroke. So there is no blood supply to any of the parts that are supplied by the anterior and middle cerebral artery, but middle cerebral artery specifically. And then you can see here how it can affect on the right-hand side on the CT and MRI, how it can impact them. So on the CT, you can see a hypo-intensity where the stroke is and loss of gray white matter differentiation. And then on the MRI, we will have a DWI form of MRI scan, which shows us if there is restricted diffusion, which we can see here, which is correlating with the middle cerebral artery being occluded. The partial anterior circulation syndrome, it's usually, instead of having all these three, which is hemiparesis, dysphasia, and homonymous hemianopia, you'll have 2 out of 3. So you'll either have just dysphasia or visualospatial neglect, or you have hemiparesis, hemianopia, or hemiparesis and dysphasia. And usually it will not be the proximal middle cerebral artery, but rather a branch of the middle cerebral artery. And that's why you don't have all these domains being affected. And you can see here, for example, it's part of what's being supplied by the middle cerebral artery is affected. So we can see a hypodensity on the left on the CT, and then hyperintensity or restricted diffusion on the right-hand side. These correlate to different patients, but it's just to show you how it can affect it. And then posterior circulation syndrome, it's usually you see either an isolated hemianopia or cerebellar syndromes. And usually you'll find that one of the posterior circulation arteries are occluded. That could be either the vertebral artery, which is the most distal, or the basilar artery, which covers the brainstem, the cerebellar arteries, or the posterior cerebral artery vessels proximally. And depending on where it is, you'll find that there are different syndromes or different presentations. So if it's mainly on the occipital part, we'll have homonopia. But if we move down to the brainstem, it depends which area is affected, and it can cause a locked-in syndrome if it's in the pons. If it's the cerebellar arteries, you'll find that there are more cerebellar signs present. So it depends where exactly in this posterior circulation it's affecting. And you can see, for example, in the CT, that there is hypointensity in the occipital lobe. On the MRI, however, you can see here that there is a restricted diffusion in the brainstem. So it depends where we have the occlusion, what symptoms we find. And lastly, the lacunar syndrome, as the name suggests, it will be in the lacuna, but the clinical features could be either a pure motor stroke without any sensory element, or a pure sensory stroke without any motor element, or you have a mixed one, which is a bit less, or ataxic hemiparesis, where it's basically just presenting with ataxia, or a clumsy hand, apologies. Yeah, sorry. Or a clumsy hand dysarthria. And usually what gets affected here is the small penetrating artery occlusions, and that's in the lenticular striae branches of the middle cerebral arteries that I just showed you, and that could cover the internal capsule as well as the basal ganglia. So we can see it on the MRI here, for example, that the part of the deep white matter changes. There are restricted diffusions here. And depending on which area of the internal capsule it covers, it can cause motor or sensory, as we discussed. Now, going through the risk factors, so we can also be thinking about how to prevent strokes from happening. We need to know that a diet that's high in saturated and trans fats, cholesterol, and salt can actually increase the risk of stroke. So we can help reduce the risk of stroke by, one, eating fibers, and usually eating fibers can help reduce the risk of stroke by up to 10%. And adults should aim to actually try to eat at least 30 grams of fiber per day, because that lowers the insulin spikes and the sugar spikes, and that consequently lowers the insulin resistance. And insulin resistance is a known vascular risk factor. So that counteracts this. So we help reduce the risk factors that contribute to the stroke. Limiting sugar is another important factor, because if you eat too much sugar, that leads to weight gain, that increases the risk of stroke by the same mechanism. So trying to limit the sugar intake and actually increase the fiber intake can actually be quite helpful in trying to limit the risk of stroke in early adulthood up into crossing the ages of 50 and 60. And there are other very important risk factors like smoking tobacco. So heavy smokers are at higher risk of developing strokes. Excessive alcohol intake can also play a role in causing strokes. And then being overweight with metabolic syndrome, physical inactivity, all these are very important risk factors that can build over time. And the younger that you are and they're present there, the more likelihood that the stroke will occur at one point in life. So if we try to control all these factors at a young age, that can help us reduce the risk of stroke down significantly, because all these build over time. They don't happen overnight. So trying to control these from as early as childhood and teenage years can help minimize all these chronic diseases. So we're going to go through some clinical cases just to help you have a better understanding of how different patients present to the straight to scan on calls that we usually do on stroke shifts. So the first case is a 72-year-old male that presents with sudden onset of right-sided weakness, speech difficulties, and visual loss. And when you ask about their history of presenting illness, they were very well until 2 hours ago. They suddenly became weak on the right side, experienced slurred speech, and could not see objects in the right visual field. When you ask about any prior similar episodes or trauma, there hasn't been any, and there hasn't been any recent infections or alcohol or drug use. The patient is known to be hypertensive for the past 15 years, but it has been poorly controlled, and he's only on amlodipine. He's also diabetic, and he is also hyperlipidemic, but he's not on any statins for that. And there has not been any prior strokes in the past or transient ischemic attacks. When you ask them about their family history, there are no family history of cerebrovascular diseases. They're former smokers of 20-pack year, and they've just quit smoking 5 years ago. He's otherwise socially active and lives with his spouse. So a question to you, what do you think are the outstanding risk factors for this patient, and which kind of category would we put him in? Is it a total anterior circulation, a partial anterior circulation, or a posterior circulation? They can tell me in the chat. Very good. And what do you think are the most important risk factor for this patient here to have that? So this patient has multiple risk factors, doesn't he? He has hypertension, he has diabetes, he has hyperlipidemia, he's also a smoker and was a heavy smoker for a long time. So there are many risk factors to actually cause him to be at a higher risk of developing this. And you guys are absolutely right. This is a total anterior circulation stroke because we have the hemiparesis, we have the visual impairments, and we have the dysphasia. So, as you can see, this is how we decided it's an anterior circulation, these three symptoms. All these are risk factors. Being a former smoker is another risk factor. When you examine this patient, they're alert and oriented, but they are slow to respond to you. So the GCS was E4, so eyes opening spontaneously. They're responding to your commands and they're able to move their muscles. And B4, he was a bit confused and dysphasic when he was trying to talk. And then when you assess him neurologically, motor-wise, he had complete weakness in the right arm and the leg. So there was 0 out of 5 power. The speech was non-fluent, and he was unable to name objects when you asked him to do so. And then when you checked his visual fields, he had a right homonymous hemianopia. When you check the cranial nerves, there is a left gaze preference. And then we check the reflexes, there is hyperreflexia on the right side where there is weakness. But the sensation was completely intact. And you checked all the other symptoms like the cardiovascular system and the respiratory system, and everything else has been okay. Now, what's important for you to know about is how we usually assess patients when they come to us as a straight to scan. So they come directly because they are in a certain window. So we need to assess them as quickly as possible because we can intervene. There is a scale that we use, which is the NIHSS scale, which stands for the National Institutes of Health Stroke scale. And this is very important for us to do a quick assessment and know which domains are affected and how much are they affected. So we check the level of consciousness, and if they're unresponsive, then they will have the highest points. If they're not alert and you have to keep stimulating them, that's a 2. If they're not alert but they're arousable, if you do a minor stimulation, that's a 1. If they're alert and talking to you and responding to you, then this is a 0. And then we check the level of consciousness questions. So you ask them which month it is and what is their age. So if they answer both correctly, that's a 0. If one of them is correct, is 1. If two of them is correct, if two of them are not correct, then that's a 2. And then you ask them to do commands. So you ask them to open and close their eyes, grip and release the hand. So if they're able to perform all of them correctly, that's a 0. If one of them is correct, it's a 1. If none of them is correct, that's a 2. And then you check their gaze to check if there is any force deviation or palsy, and you rate them accordingly. And then we check the visual field to check if there is any partial hemianopia, complete hemianopia, or bilateral hemianopia, and you score them accordingly. And then the facial palsy, again, if there's any minor paralysis, that's a 1. If it's partial paralysis, that's a 2. And if you can see a very significant paralysis on one or both sides, that's a 3. And then we check motor function for the arms as well as the legs. And if there is no drift, that's a 0. But as soon as there is a drift, we score them as a 1. And then if you check as well if they're having some effort against gravity, or they're not having any effort against gravity, or they're able to move it at all. And the worst is to score them at 4, which means that they're not able to move it. And then we check for ataxia. So if it's present in one limb or two limbs, that gives 1 or 2 scores. The sensory, we need to check whether there is sensory loss in a mild to moderate range or a severe or total sensory loss, which gives them a higher score. And then you check the language. So that is basically we're checking for aphasia. And you need to check whether they're still able to answer you, but they're taking more time, or they're not able to answer at all, and they're barely able to answer with yes or no questions. Some of them can be completely mute or globally aphasic, and that would be the worst score, which is 3. And then dysarthria, you just check if there's any slurriness of speech, and how bad is that? Is it something that you can understand, or is it severe to the point that it's very difficult to understand the patient as well? And lastly, we check for extinction and inattention. And basically, this is just to see whether they are appreciative of that one side of their body or not. And sometimes we can do a visual test where you get your hand very close to their eye very quickly, and that just shows you if they like startled by that, that means they're aware of both sides of their body. But sometimes if they're not able, and sometimes even when you're talking to them, if you're on one side where they are having a neglect on that side or inattention to that side, they're not going to be able to appreciate where you are, and they will keep looking at the other side. So that shows you that there might be inattention in that stage. So as you can see, it's detailed, but it takes us not more than 5 minutes to do that with the patient. And for the language, we show them different pictures, about 5 pictures, and we ask them to repeat sentences or repeat certain words, and then describe a picture quickly. And that usually doesn't take more than 1 minute. But then this is very comprehensive to know exactly which domains are affected. And depending on the score they get on that scale, we decide what we need to do. So the higher the score, obviously, the worse that the function is. But our cutoff for this is basically 6. So if the patient is scoring less than 6 overall, then we just do a CT head and basically proceed forward from there. If they are more than 6, then we usually also do a CT angiogram and a CT perfusion scan, and we're going to discuss that in a bit more detail, because then most likely there will be a target which we can appreciate on a CT angiogram or on a CT perfusion scan that will help us be able to intervene in the best way possible for patients, specifically in thrombectomy. So essentially, the kind of steps that you need to be thinking about when you're seeing these patients is, one, I need to do my A to E assessment. I need to take bloods quickly. I need to check their blood glucose quickly, make sure it's not too high or too low. And then we do the brief history and exam, as I just showed you. NIHSS score is very helpful with that. And we just check with the ambulance who brought the patient in and the paramedics, what was the time of onset, the risk factors. And then we go through contraindications to having thrombolysis fairly quickly, according to the past medical history, and if the patient is able to give answers or their next of kin. We also need to check the blood pressure promptly, and it's allowed for them to have a moderate hypertension within a certain range, and we don't intervene unless it's required. And then the NIHSS, which grades the severity of the stroke. It's important to mention that for the blood pressure, as long as it's systolically under 220 in an ischemic stroke, we don't really intervene, even if we're giving thrombolysis. But if it is more than that, then it's a contraindication for thrombolysis, and we have to lower it down in order to be able to administer thrombolysis, because then that increases the risk of bleeding. So we have to check this and the blood sugars very promptly, because that is one of the main, these are one of the main 2 things that we need to consider when giving thrombolysis, because if the blood sugar is too high or the blood pressure is too high, then it's a contraindication, and we need to lower it down before even considering a thrombolysis. So these are the first things to be checked. Then you send them for urgent CT head, and as I said, depending on the score, it can be plus minus CT angiography, and then we decide whether the patient is suitable for thrombolysis, plus minus mechanical thrombectomy. Sometimes we do both in certain situations, or are we going to just medically treat them with aspirin 300? And then the next stage, which is after this hyperacute stage, is going through an investigation of the cause. So you go through a more detailed history and examination, do bloods, do imaging like an MRI, and you screen and prevent complications. So things like dehydration increases the risk of hypercoagulability. Aspiration in these patients is usually high. Venous thromboembolisms, pressure sores because of lack of mobility, infection and depression. We need to address all of these and prevent them. And then establish a secondary prevention for the stroke, which is through medical as well as lifestyle modifications and surgical modifications if needed, which we're going to discuss a bit later. And then the final chronic stage, which is the rehabilitation, would involve physiotherapy, occupational therapy, and if needed, speech and language therapy for these patients. So that summarizes the kind of steps that we take in the hyperacute stages, acute stages, and then on the long term, what we need to do. So As I told you, we will start with a CT head, which is usually an contrast, and that helps us see if there's any major bleeding that would prevent us from giving any thrombolysis, any loss of gray white matter differentiation, because that can give us an indication that there is a stroke ongoing. So here, for example, you can see on the left side that there is a loss of gray white matter differentiation in the frontal and the parietal lobes, which could indicate that this is a left middle cerebral artery occlusion. When we do a CT angiogram, you will see that there is occlusion of the left middle cerebral artery, which correlates with what we're seeing here. So proximally, it would be like this. So anything beyond here is not being supplied with any oxygen or nutrition, which then corresponds to the ischemia and the infarction that we see. And then we also need to do a blood work checking the HbA1c and the lipid profile. And as I told you, the blood pressure and admission. So in the patient that we had, there are all these things that were seen on his CT scan. And then this shows you the CTA. So as you can see here on the right side of the screen, this is a CTA, and it shows on the left side that the middle cerebral artery is proximally occluded, which then correlates with the left frontal and parietal lobes being infarcted. And then here on the right side of the screen, but the left picture there, you can see that there is also what we can appreciate on the left side, the occlusion, because it's hyper intense and you can't see any follow-up after that. So that could indicate that there is a blockage there. That's not always appreciated, and sometimes you really need a CTA to be able to see that. CT without any contrast will only be able to show you if there is bleeding and major infarction. Otherwise, you don't really see if there is any ongoing process usually. And then the CT perfusion scan just shows you how much perfusion is going into there. Is there a penumbra? Is there a reversible areas of reversibility which we can work with for thrombolysis or thrombectomy? And then with each area that looks like there's not getting enough blood supply, you subtract basically some scores. So the lower the score, the worse the perfusion is. And basically, just for you to understand what the CT perfusion basically checks, it checks the cerebral blood flow. So it measures the rate of the blood flow to the brain tissue. And if there's a significant reduction, that indicates there are areas of ischemia. It also checks the blood volume and reflects it within a given amount of brain tissue. So if it's decreased, that corresponds to an infarction, which is an irreversible damage to the tissue. And then there is mean transit time, which represents the average time it takes for blood to pass through a specific region of the brain. So if that's prolonged, that basically suggests that there is a delayed perfusion, which is seen with ischemia or blockages. So it gives us very important information about how much of the tissue is having reversible damage and how much of the tissue is completely infarcted. And then that helps us make the decision on whether to do thrombolysis, thrombectomy, or a mix of both. And that usually also depends on the timing they presented in, which I'm going to discuss shortly as well. But that helps us assess the situation and be able to make the correct decision with the best outcomes and least amount of complications. So now we've talked about what are the risk factors, what is the pathophysiology of the stroke, how do we, and we've talked about the workup to do for the stroke in the hyperacute and the acute stages. How do we manage? Now, the most important one and the known one is the intravenous thrombolysis. And this has been used as early as 1995, and according to a trial that showed that patients have improved outcomes with it. And then the inclusion criteria and timing and contraindications for this is very important to know. So we use usually alteplase, and it's a treatment that we started as soon as possible, but we need to check that the patient is within a 4.5 hour of the onset of stroke symptoms to be able to say that we can give it. And there are appropriate imaging techniques that have excluded the intracranial hemorrhage, which then would be a contraindication. With intravenous thrombolysis, there has been changes in the guidelines in the sense that if patients wake up with a stroke, we count it from half of the time they were sleeping. So if they're sleeping for 8 hours, you count 4 hours from their onset of sleep, and then you count as if the stroke has happened then. So if that is within a 9 hours time frame, then you can do a delayed thrombolysis, but that's usually a consultant-led decision, and we need to check all these imaging that will help us then make a final decision on that. So that's for intravenous thrombolysis. Mechanical thrombectomy, there has been many recent trials like Extend-IA and Diffuse-3, which has supported thrombectomy, but it again has its own inclusion and exclusion criteria. But for you to be aware, intravenous thrombolysis, what I need you to know is this exclusion criteria, because we run through it quickly when we're planning to do that. I mentioned to you the most important ones, which is hypertension and high BMs, but also we need to check, is the patient having only minor or rapidly improving symptoms? That might make them unlikely to need thrombolysis. If there is hemorrhage on pre-treatment on CT, that's complete contraindication. If they have a suspected subarachnoid hemorrhage, that's definitely contraindication. Any active bleeding from any side, or any recent GI or urinary tract hemorrhage within the last 3 weeks. If they have a platelet count less than 100,000, if they had a recent treatment with heparin, or they have APTT above normal, if they had recent treatment with warfarin, or the INR is elevated, or any recent major surgeries in the last 14 days, any myocardial infarction, pericarditis that's ongoing, any neurosurgery or recent trauma within the last 3 months, any arteriovenous malformations or aneurysms, or any history of previous intracranial hemorrhage ever, recent arterial puncture at an uncompressible site, and recent lumbar puncture, blood pressure that's consistently above 185 over 110, that will make you less likely, if they're not responding and going further down, then it's less likely that they will be suitable for thrombolysis. And then, as I told you, abnormal blood glucose, so too high or too low is a contraindication. And suspected or known pregnancy, active pancreatitis, or epileptic seizures at stroke onset. So these are important to remember, and generally we'll have a checklist when the patients are there, and we'll just go through these things quickly and see whether they fit any of these, because if they fit any of these, then they're not going to be able to go through thrombolysis. And we do that usually quickly, check with the patient, check with their next of kin, check their records quickly to make sure that they're all safe to receive that if they meet the criteria. Now, the thrombectomy, on the other hand, as I mentioned to you, it's usually we do it as soon as possible, or within 6 hours of symptom onset. Sometimes, and a lot of times, we can do it with intravenous thrombolysis if there is no contraindication. And usually we do it for acute ischemic stroke and a confirmed occlusion of the proximal anterior circulation, which we can see on a CTA or an MRA. Now, as I told you, there's delayed thrombolysis and there is delayed thrombectomy, in the sense that patients who were last known to be well between 6 and 24 hours previously, who have had an acute ischemic stroke, and we have confirmed the occlusion in the proximal anterior circulation by the CTA or the MRA, and we can see on the CT perfusion scan that there is a potential to salvage some brain tissue. That basically it's showing limited infarct core volume, then we can do a thrombectomy between 6 to 24 hours according to when they will last seen well. So as you can see, there is a delayed thrombolysis or delayed thrombectomy if we don't know exactly when it happened or they woke up with it, so we can calculate it from when they were last seen well. And that's almost always a consultant-led decision, because it comes with its own risks, and we need to balance the risks and the benefits and explain to the patients before we proceed forward. Now, consider thrombectomy with intravenous thrombolysis as soon as possible for patients that have been known to been well in the last 24 hours, who have a confirmed occlusion, again, of the proximal posterior circulation, like in the posterior cerebellar, basilar, and that's demonstrated on CT or MRA. And again, we can see on the CT perfusion that there's salvageable tissue. So that's for the posterior circulation. Specifically, we can do both up to 24 hours, depending on the CTA and the CT perfusion findings. So that gives you the interventions that we do hyperacutely. But we also, after that, need to investigate after that hyperacute management, because we need to diagnose why this happened, especially in young people, rule out any stroke mimics that could present similarly, identify the etiology, guide the risk factor modification, and then prevent and treat complications. So what do we usually investigate? We investigate the basic bloods that you all know. We check the FBC to check the hemoglobin and the hematocrit, to check for any anemia, hemoglobinopathies, white blood cells to check if there's any infection or endocarditis, platelet count if it's high or low, ESR because that could be an indication of autoimmune diseases, UNEs to check hydration status and guide drug treatment because any kidney impairment can impact how much you can give. Lipid profile, as you know, high cholesterol, high triglycerides are important risk factors. And then LFTs, again, it's very important because it can affect the clotting and it can guide, again, the drug treatment. CRP to check for any infection, and clotting screening just to check for APTT, PT, and fibrinogen. And again, it's important to guide management. And then the glucose and HbA1c to check for diabetes as a risk factor and whether it's controlled or not controlled in patients who are otherwise well known to have diabetes. And then we do ECG to check for any cardiovascular risk factors like previous MIs, atrial fibrillation, or flutter. And we almost always do a 72-hour tape to check for any arrhythmias that might have caused any TIA or stroke episodes. And then we do carotid Doppler ultrasound because that can show us if there's a significant carotid stenosis that requires intervention and could possibly be related to the stroke that happened. As you know, any stenosis there could make it more likely that a stroke will happen because of decreased circulation. Echocardiogram is not done in all instances. If we're suspecting it's embolic or we suspect there's an endocarditis ongoing, then we can do an echocardiogram, but you have to have a suspicion of either or to request this. And then lastly, the MRI is very important. We usually do it after we do the CT, and we need to look at, is there any multi-territory infarcts, and is there any restricted diffusion in certain areas that were not seen on CT, and we want a better idea on MRI. And if patients have an MRI contraindicated due to a pacemaker, any sharpnel, any metal work in their body that could prevent it, then we can do another CT head to check again if there has been any changes over time. And this is similar to the pictures I showed you earlier on when we were discussing different types of stroke. Now, in a young patient, in addition to everything that I just mentioned, you also need to check HIV, vasculitic screen, thrombophilia screen, homocysteine, because all of these could actually present with multiple strokes. So we need to check these to make sure that patients don't have these risk factors. Cardiac investigations. In patients who are very young, we should consider doing a 7-day Holter monitor, implantable loop recorder, transcranial Dopplers, transesophageal echoes. And then we need to do vascular imaging if we haven't done already in the initial stages, like CT angiography or MR angiography, to basically check if there is any kind of risk factors that we could see on there. So when we do a thrombolysis for patients, we need to make sure that we are repeating the NIHSS as well as the CT head in 24 hours. Why? Because with thrombolysis, there is a high risk of hemorrhagic transformation for this infarcted stroke. And therefore, if we don't check the NIHSS and CT head, we might risk actually not finding signs that could have indicated that there is a start of a hemorrhagic transformation and promptly imaging and treating it. So that's why it's now a rule that we always do an NIHSS score and repeat CT head imaging at 24 hours to be able to promptly catch this and treat it as required. Now, the secondary prevention after we've finished all of this is that patients need to be on something of an antiplatelet long-term. So we usually, if you have given the thrombolysis already, then we usually start them on aspirin for 2 weeks, and then we give clopidogrel, and that's not obviously in the first 24 to 48 hours of thrombolysis, but after. We give it for 2 weeks, and then we switch them to clopidogrel, and they usually stay on that lifelong. And this has been supported. But clopidogrel can also be given for patients who are intolerant to aspirin for any reason. We usually give aspirin and clopidogrel as a dual antiplatelet therapy in cases where there is a high-risk patients that are presenting with minor strokes. Then it's better to cover them with a dual antiplatelet therapy for 3 weeks, and that has shown to have better outcomes. And then you need to consider anticoagulation therapy for patients who were found to have atrial fibrillation, and you can use either DOACs or warfarin. And basically, there has been multiple trials to show that there has been efficacy of DOACs over warfarin for stroke prevention in AF patients. And then recently, there has been 2 trials that has been published just in the last couple of months, which are Optimus and Catalyst trials. And they have showed that we can start early DOAC administration following an ischemic stroke. And that's actually superior to starting the DOAC later. So what we used to do is that we used to, if the patient is already on DOAC, you stop it for 3 days. If the patients require a DOAC because you found an atrial fibrillation, then we used to wait at least 3 days and sometimes up to 7 to 14 days to start it because we were worried about hemorrhagic transformation. But as per these recent trials, it does show that we can start it as early as 48 hours in patients, and that doesn't impact the outcomes. And then obviously you need to manage the hypertension, the diabetes, and the hyperlipidemia. And we usually tell the GPs to keep these things at check. So we tell them that the target blood pressure is less than 130/80. With diabetes, we need to have a tight glycemic control, and that's with HbA1c less than 7%. And with hyperlipidemia, we usually ask them to check the non-HDL, and that should be less than 2.5. And that has been very specific for stroke. So the higher it is, the more risk that the patients have for another stroke. So we aim for a 30% reduction in the non-HDL cholesterol, and that comes with better outcomes for patients if it's better controlled. And then obviously, importantly, is the smoking cessation, dietary changes, and physical activity, because these lifestyle modifications can play an important role in also managing blood pressure, cholesterol, diabetes, and generally decreases the risk because of this and because of its overall effect on the body. So smoking cessation, it reduces the stroke risk, and the studies have showed a marked decrease in recurrent strokes after patients quit smoking. Dietary changes, specifically Mediterranean diets, because they're rich in vegetables and fruits and whole grains and healthy fats, they've been shown to help reduce hypertension and diabetes and therefore reduce the risk of stroke. Physical activity, which is very, very important. Regular exercise is usually reduced with stroke risk. And obviously that can be built over time. Depending on the degree of stroke, patients could take some time to be able to get back to their baseline, but then staying and remaining very active will help them to prevent any subsequent stroke happening. Obviously, any alcohol or recreational drug use, patients need to be warned about this and how it can affect the risk of having a stroke. And importantly, what I need you to know is there has been a lot of patients that we've seen that uses cannabis on a regular basis. And unfortunately, we have seen that there is a correlation between this being used and increased risk of strokes. So this is one of the things that have been seen in correlation with quite a lot of patients we see. And driving advice is very important. So the minimum is that they can drive for 1 month, and that is if they have recovered quickly. And that we usually see if we do thrombolysis or thrombectomy is that they have very minimal neurological deficits. These patients can continue to drive after 1 month, but otherwise, if they still have continued problems with mobility, whether in the upper limbs or the lower limbs, then they need to inform the DVLA. Then they need to be reassessed over time until they get to a point where it's safe for them to resume driving. And obviously, MTT approach is the key. So nursing, physiotherapy, occupational therapy, speech and language and therapy, they have to be involved very early on. And the earlier on involvement of the physio, occupational, speech language, the better the outcome. Nursing, it's very important for them to keep checking the clinical status and the progress with the blood pressure management, administration of the medications, nasogastric feeding in patients who are having problems with dysphagia or swallowing difficulties, and preventing any pressure sores because of the decreased mobility. Physio are very important to help regain the strength, the balance, and the function of whatever they have had deficits in, and prevent spasticity because early movement prevents the spasticity from occurring, which is a big problem in patients who have strokes. And then chest physiotherapy in patients who have problems with sputum clearance because of that weakness. They can help quite significantly with that. Occupational therapy, as you may well know, they do functional assessments. They plan ahead for patients' future needs when they go home. And they also check their cognitive and mood screening and see what can be done before they go home and after they go home. And then speech and language therapy, obviously, they help with the swallowing impairments and the communication impairment in dysphasias. So their involvement early on is very vital. And orthoptics is important in case patients have foot drop or they require any help with their limbs. Dietitians and social workers are also vital because we need to put some dietary plans in place for patients short-term and long-term. And social workers will assess with the psychosocial support. Now, the surgical interventions or the procedures are things like Botox injection, which we usually do for spasticity for patients who have stroke, and that we usually start with baclofen and we titrate the dose accordingly. And if the patients don't respond very well or they're having minimal effect with that, then we can use Botox injection to try to relieve the spasticity, and that usually works very well. If there's a dysphagia ongoing and it's not improving quickly, then we need to consider longer term NG feeding or PEG feeding, depending on the degree of dysphagia and how much help they need and whether they're not having enough intake as required. And most importantly, as you may well know, venous thromboembolism, we need to prevent that. And that's why patients tend to be on either TED stockings or pneumatic compressions or dalteparin according to which stage they're in. So obviously, if they've just had thrombolysis, this is contraindicated and we keep them on pneumatic compressions. But then after that acute stage, within 3 to 7 days, the dalteparin could be started unless they are on a DOAC, in which case then you don't need to put them on anything of that sort because DOAC can cover for that. Other things you need to know is that with baclofen, there are other medications that we can use for spasticity, like tizanidine and dantrolene, which is important for you to be aware of. So there are multiple things that we can use before moving to Botox injection. Botox injection has been shown to improve generally outcomes, and they can see the effects as soon as a week after injection. And then, as I told you, we usually do an ultrasound carotid Doppler, or we can see it on CTO and MRI because we need to check for any carotid stenosis. If it's more than 70%, then we would recommend, and if that's on the side of the stroke, then we would recommend a carotid endarterectomy, and we would refer them to vascular surgery. Alternatively, they can have carotid stenting. But this is very important to manage, especially if it's on the side of the stroke. If it's not on the side of the stroke, it's still recommended, but then it will not be as urgent as it will be if it's on the side of the stroke. And then malignant MCA syndrome, which is the hemorrhagic transformation that can rapidly progress and worsen. One of the most important things to be aware of is decompressive hemicraniotomy. And we need to, as I told you, appreciate any change in their GCS or their neurological deficits and repeat the CT in 24 hours to be able to pick that very promptly and then discuss with neurosurgery about the suitability for decompressive hemicraniotomy, because that can save lives. So promptly assessing and involving the right team is very important and vital. And then posterior circulation strokes, they have high risk of developing hydrocephalus. So extraventricular shunt or posterior fossa decompression are a few of the things that we can do to help manage patients. And that usually presents with symptoms of increased pressure, and you can also see it on scans. Lastly, we're going to just go quickly through the rehabilitation process, which can take up to a few months, up to 6 months, and sometimes up to 12 months with patients, depending on the degree of the disability that they got from the stroke. So the speech and language, they basically address aphasias and other language disorders and evaluate and treat dysphasias or swallowing difficulty. And obviously, with early intervention, there is a significant improvement in communication outcomes as well as nutritional status and reducing the risk of aspiration pneumonia. Physiotherapy, it improves the gross motor skill, balance, and gait, and enhances the muscle strength and functional movements very early on. And usually that leads to an improved mobility and reduced length of hospital stay, including the rehabilitation stay. And that improves also the activities of daily living and overall functional recovery of the patients. And generally, MDT management optimizes the outcome because patients will be discussed on a very regular basis and adjust their treatment plans and what they need accordingly. So this basically now covers the ischemic stroke. Now we're just going to have another case quickly about hemorrhagic strokes and how we usually manage them. So this is a patient who's 58 years old and she works as an office manager. She's a smoker of one pack per day for the last 30 years and she quit 2 years ago. And she has an occasional alcohol use, so drinks, 1 to 2 drinks per week. And when you ask her about the family history, her father had a history of hypertension and stroke at the age of 65. She comes to you with sudden onset of severe headache, and she tells you this is the worst headache of her life, and it's accompanied by nausea and confusion. When we check about her past medical history, she's diagnosed 10 years ago and she has poorly controlled hypertension with an average readings of 160 over 100. She is having hyperlipidemia on statin therapy, but again, she's not compliant with dietary recommendations. Her diabetes mellitus was diagnosed 5 years ago and it's poorly controlled with an HbA1c of 8.5. And she had a transient ischemic attack 2 years ago, but she had no prior imaging or interventions. So as you can see, there are a lot of things that stand out. She's a smoker. She has a family history of stroke. She had the worst headache of her life, which is usually a sign of subarachnoid hemorrhage. And she also has a poorly controlled hypertension, diabetes, hyperlipidemia, and she also has a previous stroke. So all these are very important risk factors. When you examine her, she appears distressed and she's in discomfort. When we check the blood pressure, it's really high. It's 208 over 110. Otherwise, her heart rate is 96, so a bit on the tachycardic side with respiratory rate of 20 breaths per minute and a normal temperature. When you examine her neurologically, she is alert but confused, and she's responding to verbal commands. And when you check her cranial nerves, her pupils are equal and reactive, but she has a left-sided facial droop that you note on examination. You check her motor function. Her right arm and leg are absolutely fine, so they're 5 out of 5, but the left arm and leg are 3 out of 5, and there's weakness on the left side. With the sensory function, you find that she has decreased sensation to pinprick and touch on the left side. And coordination, when you ask her to do the finger to nose test, she actually has a difficulty on the left side. But the reflexes show an increased deep tendon, again, on the left side or the affected side. So we can see there are focal neurological deficits, basically involving the left arm and leg, and that is also causing ataxia and a degree of sensory impairment, as well as a facial droop. Now, this patient, you do a workup as we discussed. So you do a CT scan of the head, and that actually shows you a large left-sided intracerebral hemorrhage, and that measures approximately 5 centimeters. There's a surrounding edema and a midline shift to the right. So as you can see in picture A, and this is basically also involving an ventricular hemorrhage. And then when you do a CT angiography, you're checking if there any vascular abnormality, and there is a ruptured aneurysm in the left middle cerebral artery territory, as you can see here, which is pointed with the arrow on the most right-hand side. And you can also see it on the picture D as well. You can see the hyperintensity there in the middle. So Essentially, this patient is presenting with an intracerebral hemorrhage and history and non-contrast CT head helps us then direct the further management. So you need to assess the risk of the macrovascular causes. Patients who are at a high risk usually are younger age patients who are less than 50 years old. There's no history of hypertension. There is a low bar location to it, and no CT signs of small vessel disease and primary intraventricular hemorrhage that could be seen. While the lower risk are patients who are a bit older and they have a history of hypertension, there's a deep location to the bleed, and there are CT signs of small vessel disease. In such cases, there is no urgent indication for further imaging. But if the patients are higher risk, then you need to do a CTA. And if the CTA is positive, then there is a high yield of the intra-arterial DSA. And that's one of the ways that we can see the blood vessels more clearly with subtracting whatever is behind them so that we can see it very clearly and see whether there is any vascular abnormality. If the CTA is, however, negative, then we need to check, is there any evidence of small vessel disease? If no, then there's an intermediate yield if we do a DSA. If it's a yes, and there's a history of hypertension, then doing a DSA is not going to help quite significantly. And here you see the evolution of any intracerebral or intraventricular hemorrhage. We have an expansion of the hematoma, and that causes early deterioration. And then basically, with time, you'll see that there is a perihematomal edema, and that occurs in most patients and then can contribute to the mass effect and increased intracranial pressure, so edema surrounding the hematoma, and then that can either resolve by itself or require surgical intervention to resolve. Now, with intraventricular hemorrhage, the problem is it can cause obstructive hydrocephalus, and we see that up to 50 to 60% of the patient. And the CSF flow usually is obstructed by the clot and requires actually an urgent drain insertion. So this is something to be aware of. If the patient is showing early signs of intraventricular hemorrhage, we need to be aware that they're at very high risk of hydrocephalus and might need surgical intervention. So this is something that I just want you to be aware that patients who are on anticoagulation and in cases of intracerebral hemorrhage, there are ways to reverse it. So for example, warfarin, vitamin K reverses its effect. If the patient is on dabigatran, there is adacrizumab, and that usually can reverse its action. If they're on apixaban or viroxaban, edoxaban, then you can give them andexanet alpha, and that's an intravenous bolus, and that usually helps reverse. And lastly, heparin, protamine sulfate is usually a good reversal agent. So whatever they are on, if they're in cases of intracerebral hemorrhage, there are things that can help reverse this process and reverse the effect of the DOACs or the anticoagulation. And basically, there are more strict guidelines for bleeding than for ischemic stroke. So for blood pressure, we need to make sure that there's a reduction in blood pressure in these patients, and it should be, if they're having any systolic blood pressure between 150 to 220, we need to reduce that, and that needs to be between 130 to 140, and that's very strict. And you'll find that neurosurgery are very strict about this, because if it goes beyond that, the risk of hematoma expansion becomes a lot higher. So they're usually in a monitored environment, and we need to make sure that it is within that tight range. And we need to make sure that within the symptom onset in the last 6 hours that we're bringing that down. In most cases, that we should aim to achieve the target blood pressure within 1 hour of starting the treatment. Rapid blood pressure lowering should be avoided, especially if there's increased cerebral pressure and the GCS is less than 6, or there's a neurosurgical evacuation pending. So we need to be careful about the circumstances with this. And as I told you, there are protocols to help reverse any anticoagulation. And pre-hospital treatment with glyceryl nitrate apparently appeared to worsen the outcome to help lower the blood pressure in a subgroup analysis of patients. So ultra-acute treatment may actually be harmful in such circumstances and should not be used. Once they're in the hospital in a monitored environment, we can give them a GTM patch. And this just shows you different neurosurgical techniques that can help with intracerebral hemorrhages. There's open craniotomy, there's minimally invasive surgery with clot lysis, there's external ventricular drainage, and then there's decompressive craniotomy. And the approaches are different depending on the location of the intracerebral hemorrhage, the extent of the intracerebral hemorrhage, and the patient's status, whether their GCS is low, intubated, ventilated. So there are multiple factors that play a role in how the neurosurgeons decide how to treat this. And lastly, I just wanted to discuss with you about certain considerations that have been in recent research trials. So it has been seen that with patients who have mild ischemic stroke with a low NIHSS of less than 5, there has been a discussion, but we need a larger trial to be able to establish that whether dual antiplatelet therapy is actually better versus having thrombolysis in these patients, and which one carries a better outcome. There has been research that showed that thrombolysis in these patients does carry a better outcome, but there hasn't been any established large-scale study that can help us make that as a guideline once and for all. But this is something to keep in mind when you're assessing patients with low NIHSS score. And then recurrent strokes in patients that are having optimal secondary intervention. There has been studies that showed that colchicine actually is a good agent to try in patients who are failing to respond to secondary intervention and they're having recurrent strokes. But again, we need larger studies, but this is something that has been studied a lot recently and something to consider. And then lastly, if the patient's having further AF-associated strokes, despite being on DOACs, they are usually suitable for a left anterior appendage surgery in the heart, and that usually was associated with decreased risk of having any further embolic strokes relating to AF. So these are points that you need to be aware of because they might reach the guidelines at one point if there are larger studies. The suitability for the LAAO is something that is very well established, but this needs a senior assessment and referral to be done. But the first two is something that could potentially change over time. So it's good for you to be knowing about these recent studies, essentially. These are the references that I have used. Thank you so much for listening. And if you have any further questions, whether it was about stroke generally or neurology, internal medicine training, I'm more than happy to be contacted by email, which you can see here. Thank you so much once again for listening. And I will be staying for a few minutes now if you have any questions, and I can reply on the chat. Thank you. Thank you so much. Thank you so much. I'm really glad that you found it helpful, and please feel free to ask me any questions regarding any of your future steps or this whenever you want, and you can freely contact me on my email. Thank you so much for attending. I'm more than happy to share the slides. I'll just check with the coordinators for this if they can send it through to all of you, whoever has attended today. And if not, just drop me an email on my email and I'll send the slides through. If we can't get them to be sent to all of you, then you can contact me individually and I'm happy to share it with you. No worries. If there are no further questions, I'm just going to conclude this lecture. Thank you so much for listening once again, and I hope you find this useful and good luck with all your exams. Thank you so much.